The purpose of this session is to highlight the importance of the fact that if you are, for example, if you are preparing for an exam and you happen to find some recall questions, how to use them. Okay. Because to start with, if you don't have the background knowledge and if you jump directly to these questions with the point of view that you will be able to pass the exam, so maybe if you have a very good grip and you have very good cramming skills, you may be able to, because MCQs is just like there is always an element of luck, because in MCQs maybe you select without any sense any option and it happened to be the correct answer. Even then you don't have the knowledge, you may pass the exam. So but as a great ambassador to represent my specialty. I'm totally against, and I feel insulted when I come to know that the people are so enthusiastic to follow such crap and nonsense pools, and they are not looking at this scenario in a bigger perspective, and they are very much happy that they have an assurity that no problem, 80% question will come from this pool, and no matter we don't know or don't know, we will be able to pass. So unfortunately, you at the end of the day, you are playing with lives of human beings who are someone's relatives, brother, sister, mother. So you are not living in a jungle. You also have a family, and you will never imagine your family members to be treated by some people who pass the exam by this terrible shortcut. So first of all, this is very important thing. I'm just killing this time so that some more people join, and then we will start looking at these MCQs. Okay. Um, because such MCQs are there in every part of world. Okay, even in Saudi Commission exam they have, but for those there are like the Saudi residents, they have MCQs based system. So they have a pool which is a number of questions repeat from that pool, but they are using it with a sense that they are just trying to probe the answers. They are just trying to find the references, and they are not relying wholly solely on that source. Okay, because I recently came to know that this is a book which is being literally followed by my our people back in Pakistan. Okay, so I really wish to contact this person who has uh, compiled this book, and like literally I'm short of words to explain my feeling, because this is a disaster. If that person has written a book, uh, okay, with a purpose of getting some finance, I don't know how this book is printed, because I have only seen the PDF. Okay, but I have heard that this book is being printed and people are buying it, and I don't know what they are doing. So if you just see the first page of this book, the first this person has just tried to tell the dermatomes. Okay, so if you Google it, the dermatomal level, you will find in 1 minute the answers. So this was a disastrous on point which is mentioned here. Okay, because foot and ankle surgery is not L2. Can anyone correct it? What will be the dermatomal level for foot and ankle surgery? Yes, please. Arifa, am I audible to you? Yes, Imran. Anyone wants to speak out? Yes, please, Dr. Ali. Do you know that what will be the answer for this foot and ankle surgery? Is it L2?
Sir, I guess L4, L5.
No. Just have a look on the dermatome. Okay.
ਸਾਡੀ ਬੱਚੀ ਬੜੀ ਗੌਰ ਨਾਲ ਬੜੀ ਤਵੱਜੋ ਦੇ ਨਾਲ ਫਿਰ ਉਹ ਆਪਣੀ ਲੈਪਟਾਪ ਤੋਂ ਲਿਖਦੀ ਹੈ ਕੀ ਦੇਖਿਆ ਕੀ ਕੀਤਾ।
Who answered L4, L5?
Sir, Imran.
Yes, Imran. Just imagine, you know, it will take few minutes to find the answer. Just have a look. Is it L4, L5? It is definitely some portion of S1 and S2 as well, in addition to L4, L5. Okay. So actually there are two different sort of questions which they can ask. One question will be what dermatomal level will be required if a surgery is being done. For example, if they have put a fracture surgery, they, even though this will be the area where they are, for example, operating in the foot, but still there may be a tourniquet which may be around here. Okay. So in that case, this dermatome and this dermatome level in the calf will also be involved, because they will put a tourniquet here. Similarly, if you will go up, similarly, whenever they are asking you about a surgery, usually majority of the orthopedics people, they will not do it without a tourniquet. So whenever there is an involvement of tourniquet, you should be thinking that you should be covering the area of tourniquet supply as well. Okay. So this is absolutely wrong. Please correct it. Okay. This is not L2. Definitely. This is not L2. This is wrong. Okay. And if, for example, if we see that she is telling about the spinal level which is required, even then it is wrong. Okay. Even then it is wrong, because it will not be L2. It will be maximum L4, L3, but it will not be L2. So in whatever way this statement has been written here, it's wrong. Okay. Similarly, vaginal delivery, hip surgery, TURP bladder, yes, maybe it is correct. Okay. And intestinal, gynecological, urological, urological gynae, T6. I don't know what is in the mind, because there is this question will not be asked in that way. They will be telling you some scenario that this surgery has been occurring, and which level would you like to have. So, for example, gynae surgery, maybe, for example, if it is laparoscopic surgery, or if it is open surgery, the level will be accordingly. Okay. So don't try to cram that it was written in this book T6, so you should be ending at T6. Okay. So can anyone tell why bladder TURP surgery required T10? Why TURP surgery required T10? You know, this is an interactive session. People will not speak out. I'm wasting my time then. Anyone know why TURP surgery required T10?
Sir, irrigation के साथ with irrigation there will be effect on peritoneum as well, or some sort of stretch on it.
Not peritoneum stretching. Yes, Dr. Shelly Rana. I'm sorry. Actually, when there is irrigation,
nerve jerk preventing.
No. What is the etiology of this jerk? Can you tell me that reason, Dr. Shelly Rana? Don't hesitate. The good part is that I cannot come through the laptop. Okay. So just feel free to answer anything. Even in wrong answer will result in getting the right answer. Okay, your point is correct, but this is not the reason.
Basically, the spinal anesthesia doesn't cover it.
Yes, actually, why this obturator reflex occurs? This is because of involvement of the lateral wall, from where lateral wall of bladder, from where obturator nerves are passing. Okay, so this is due to direct stimulation of obturator nerve. And obturator root values is L2, L3, L4. T10 level required for TURP is because of stretch of the bladder. Okay, so bladder is supplied by T10. So that's the reason. Okay, Imran, you are clear? Okay, Imran.
Yes, sir.
Okay, so there are so many
Can
points.
you repeat the answer? Sorry, I didn't get you.
Yes, T10 is supplied by the bladder, and whenever they are doing TURP surgery, they are irrigating, okay, and the bladder is distended. So because of bladder distension, T10 involvement is there. Okay, so if you don't cover this, because traditionally some of the people they only give saddle, because the surgery which is where they are cutting, that level is sacral, because it's the prostate supplies from sacral roots. Okay, so the question is that, can you do TURP in saddle block? So the answer is technically no. Practically, some people are doing it, but they just sedate the patient, and the surgeons are quick and they are not over distending the bladder. In that scenario, you can do it, but in the exam, always you have to mention T10. Okay, so practical aspects are a little different
Okay.
than the clinical. And the obturator reflex is because usually it is occurring in the bladder. Of course, if the bladder is distended, it can occur, but usually it is occurring in bladder surgery, especially the tumor of the lateral wall. Okay, when tumor is involving the lateral wall, there is a chances of so either you have to do obturator nerve block, okay, or you can convert into general anesthesia with muscle relaxant. Otherwise, this reflex can occur. Okay. So the next topic here, having so many points here written, is about PDPH. Okay. So yes, this number of things written here are correct, but why are you relying on this? Why don't you go to a proper source? For example, if you just go to because you will find so many questions about PDPH. Okay, so if you are able to read it in a proper way, it will be easier for you not to miss any aspect. Usually, what is the pathophysiology of PDPH? Can anyone tell, please?
Stretching of tentoriums of the brain.
Okay, why it occurs?
Because of the loss of volume of the
When there's dura is punctured, there is some loss of CSF. Okay, and this can cause a stretch of the meninges and cranial nerves. So even that's why if you are doing like spinal or dura puncture, even for example, if you want to do a dura CSF examination, okay, lumbar puncture, even then you have to rule out the raised ICP, because if you are doing it, then it can create a problem. Okay, then another important thing, if you are, I will just try to just give you an idea, because any MCQ which will be coming will be from those points. One of the most important thing is that if they are asking you what is the differential diagnosis of PDP. Like, of course, okay, you have given spinal cesarean section. So you are expecting that this headache which is occurring is because of spinal which you gave. Okay. So what else can be the reason? Okay. So this is, you should be just knowing that Dural puncture headache is one of the reasons. There are so many other reasons. It may be because of cerebral venous thrombosis, cerebral infarction, subdural hematoma. So you have to rule out. You have to find specific reason which will point towards PDPH. Okay. And it will also be depending on how many pricks you did, what sort of needle you were using. Okay. What was the hydration status of the patient? And like similarly things like another point which some people know about it and some people don't know about it, that when you are puncturing the dura, the bevel, needle bevel should not be upward. It should be on either side, because if the bevel, the hole in the needle, if you are using the quinky needle, okay, if you are using the cutting needle, then if your bevel is pointing towards up, it will cut the dural fibers, fiber more than if the bevel is pointed, the hole is pointed towards either side, right or left. Okay, so it is advisable that when you are doing spinal, you should turn the bevel towards one side, and once you enter it, then you can turn. Like when you see the CSF coming, then you, because if, for example, if you keep the bevel on one side at that time, what will happen? Can anyone tell you? Please, all of you are requested to speak out, raise the hand and give the answers. I'm not giving a lecture. I'm just trying to discuss some important points, some important things which are being asked in MCQs exam. Because if you don't turn the bevel and the bevel direction is on one side, there is chances of patchy block. If you want the block to, because you are giving spinal at L3, L4 level, and you want the block for cesarean section to reach up to T4 autonomic, so you need to give the bevel should be upward, because otherwise theoretically when you are injecting the more, because this is a hyperbaric solution, so theoretically no matter how much quickly you are making the position, there is a chance that the effect will not be good. It will not be reaching the proper level. Okay, so this is the point, and it is important for PDPH as well. Okay, so whatever the question they are asking you about the character of the, so it is fronto-occipital. It is does not occur usually, but practically, this is again, I'm only telling practically. Practically, I have seen it to start occurring even immediately. But what is my experience? I'm not sure about the reason, but practically, I have seen, if I have punctured the dura, I saw the headache immediately. I have seen immediately. Okay, but they claim that if you have dura puncture, so maybe it is there is difference between dura puncture from epidural and dura puncture from spinal, because the spinal needle is relatively less gauge, not less gauge, higher gauge, but a smaller needle. So another point, this I'm telling you for MCQ, that sometimes they write higher gauge. So higher gauge means smaller, thinner needle. As the gauge increase, for example, 25 is thinner than 18, and 27 is thinner than 25, or 29, because even 29 gauge is available. So this is just matter of your understanding of simple English. If you don't understand, you can have a wrong answer, because they are saying higher gauge, less incidence, or you are putting in the wrong way. I hope you understand. Okay. So similarly, there will be association with the posture, and this sign they have written, which if you are giving the increasing the intracranial pressure due to abdominal pressure, the pain will be a little relieved, because this will be increasing the CSF pressure. Okay, so I've just compiled some of the articles about PDPH. The other question related to the same PDPH will be about epidural blood patch. Okay, so you can like 75% PDPH subsides within a week. I'm not sure. Okay, if you are appearing in In international exams, then definitely you should be having the findings of the data. Even in Pakistan exam, if some examiner has made, they may be asking about incidents from, like I just compiled here. This was I did not read it wholly, but I just found it that this was from the American Society of Anesthesiology statement on post-dural puncture headache management. Okay. So if they are giving you any point, there may be, like, for example, if this incidence is in intracranial subdural hematoma after a PDPH with an incidence of 1.5 per 100,000 deliveries. So if, for example, if you want to have the correct answer, and there is a problem, people are saying, oh, they have make a question in which very close percentages are written. So they have made that question from some research paper or some recommendation or some guidelines. So if you have no idea about that guideline, you will not be able to find the correct answer. Then you will be saying that, oh, what sort of question CPSP has asked. So remember one thing, the people who make the question in any society, whether it is College of Physician Surgeons in Pakistan, or whether it is in India, or whether it is in UK, they are not crazy people. Whenever they are making question, there is some reason for it. What I get the answer, even when there is a funny thing about this book. When I shared, actually I was making fun of this book, or I was just trying to discourage people. Can you believe this? I received around 20 or 30 people who messaged me, sir, kindly send this book. Sir, I said, please, this is a crap book. No, sir, we will delete after looking at it. So I was really ashamed, believe me. I have no problem, because I have dedicated my life and my time for you people. So I don't bother. If I am free, I reply and I send everything. But I tell you something, if you are trying to read this source without adding what I'm just trying to tell you, that if you are reading some topic, take the topic and read that topic from article, or you read the points and confirm it, because that person who has published this book has not bothered to confirm it. Okay. He has just, because he or she knows that people are crazy and they will take the book. So that's something I am very happy that the mentality of people across the border is the same, because I received message from Indian people as well. People from India, they were also, sir, please, because I just by mistake sent on the fast track group. So then I deleted it, and I was just thinking whether I should take the class in our Urdu language, so that only the people from Pakistan are attending, or I should share, because you will find such crap pools in every part of world. Okay. So another
So
one thing I want to
these are
clarify.
past papers.
Yes, these are past papers. So this is pool and this is half cut.
Yes.
Just tell me one thing. Let me explain to you. If you go to buy a suit, okay, and you only find half part of it, will you able to wear it? Will you able to use it properly? You will never be able to use it. So this is common sense, that like if you are using these so-called past papers, if you don't understand, because it is not humanly possible, my dear, that the person who reproduced each and every line of the text and each and every option correctly. Okay. So this is the problem, that if you are finding that, even I give you another point. Some people claim questions are coming from comprehensive, patient questions are coming from Josefa, questions are coming from Bryony Hall. Yes, it is possible that the holy examiner who had submitted the question just did not even bother to change it a little bit, and submitted and it was approved and it came into the pool. It is possible. But the problem is that, even for example, I became a devil's advocate. If I am taking a MCQ from Bryony Hall, I will definitely try to change a little bit of statement which you will not appreciate. and I will change the answer in the key which is not there in Bryony Hall. Okay, so now what will you do? Just tell me. Still you will have to use your neurons, you will have to use your brain, which you are sending on rest. You don't want to use the brain. Say that if you use it, maybe it will be decreased, but it is other way around. If you use your brain, you will be more active. At age of 42, without any impulse, without working in a teaching setup, believe me, if I sit back, relax, enjoy, watch TV dramas and or anything in that, start dancing, remember, believe me, my neurons will be relaxed. But as a ambassador of knowledge, ambassador of spreading the knowledge, I will forget everything. So I hope I'm giving a message. So MCQs will be a number of questions will be fine. Why this is PDPH is associated with lateral gaze problem, CNS, cranial nerve 6 issues due to stretch of dura. What is the reason for it?
Abducens has the longest
Yes,
course.
abducent nerve, but specifically, if I'm not wrong, it has a longer intracranial pathway. If I'm not wrong, just correct me. This is the reason that why they are not mentioning any other nerve. So because I'm just guessing it, I don't remember exactly. But if you can find the reasons, only then you will be able to have the grip of the subject. Okay, because in the exam, if they are asking you Viva, you have to appear in Viva. If you pass MCQs, what will happen in Viva? They will be asking you how to give epidural blood patch. So I tell you something. If you read here, you read about epidural patch. In my 18 years career, neither I have ever done it nor I have seen it. I have never, but in the exam, they will ask you how will you take it? How will you inject it? So if you don't cover this point here in the exam, they will suddenly ask you this question. And if you are like me, who has not done it ever, what will you answer? I hope you understand my point. Okay. So if for example, now we are covering this topic as well. So can anyone if anyone has got experience or anyone can tell how to give epidural patch and when you will stop? Because the other thing is the same sterilized area, sterile condition, taking the blood and injecting 20 to 40 ml. And when will you stop? If you, for example, if you start, what will be the problem in which you will immediately stop? This is one thing. And another thing is that, is there an option of second dura puncture? And if second dura puncture occur, what will you do? This will not be written here. I am 100% sure. You are doing an epidural blood patch, and now you happen to have a dura puncture. What will you do? They will ask such questions in Viva, I can guarantee you. What will you do then? Zishan, thanks a lot for joining. So if some of the question, because the people who have the exam, unfortunately, they are not speaking out. They're afraid of me. They think that I will hit them. So if you have been hit by me a number of times. So if you are here, please, if you can answer some of the questions, please.
Yes, sir. Sure. Inshallah, I will answer.
Yes.
And another thing, sir, if you allow me, I would like to add. Sir, it's a very long process. If you are on it that we have to clean the Ayesha Baig MCQs, I would suggest to make a small group of people, maybe 4 or 5 people, and we can have like a WhatsApp group, and with references we can correct these with writing their references also.
Zishan,
I can
always invite
volunteer
people. I always invite people, even if, for example, they are not interested in attending, or just tell me what will we do. Anyways, your suggestion is 100% valid, and I will try, just like I am always trying. I will try to do it. So whatever MCQ you can correct, just help me out. Because I know that even I put 100 MCQs books, people will be attracted to that book. So now I have to, like, just like you can see, I have to live with my mother-in-law. So this is my mother-in-law, and but your people's darling. So I cannot change your darling. So I am making my mother-in-law my friend. I'm just trying to make my mother-in-law my friend. Okay. So, so that's what I'm trying to do. So whatever, like, for example, this question I asked, epidural blood patch. So how to do it, and what will you do if you have another dura puncture, and how much volume you need to give, and when you will stop. Have you ever
It's
faced such thing? Because I have
it's
never done it in my life.
no, we have not done it, but only read it. It's a total volume of 20 ml.
Hmm.
Either 20 ml volume is delivered, or if the pain starts, if the patient starts having pain
Yes.
during the inoculation of blood, you have to stop it.
Yes, yeah, that's actually, this is that when you are giving it, I think this one here, they will be writing about this thing, because when they are giving it, because it is, you are injecting in the closed space. So if you are having that it can create the problem, and there is no role of prophylactic. If they are doing
Yes, sir,
prophylactic,
no role of
prophylactic, but may reduce the, is not routinely recommended at this time. Okay. So I will
yes.
suggest all of you to have a look, because practically even now you are relaxed. So this is actually a new source which I just found, and I have put it in the link. Okay. So these are the things interesting, because actually, I will tell you something. With the evolution of erector spiny block, a number of indications of this one epidural for post-op analgesia is all reducing, because like in certain scenarios, if you have put epidural instead of epidural, you have put catheter in erector spiny block, this is giving wonderful results with less invasive. You are not entering in the dangerous area. Okay. So actually people have gradually epidural will decrease. Even maybe I have not tried it, but I think erector spiny block may be tried for labor analgesia as well. It's my perception. I have not tried it yet, but I think erector spiny block can be performed for labor analgesia as well, at least for first stage, not in the later stage, but for the first stage, for the initial part, it will cover, in my opinion. Okay. So anyways, okay. So any other question which you faced, any one of you, in the MCQ exam related to PDPH, and any other question which you remember? Zishan, for this lateral gaze problem, CNS6, this abductor nerve, I just was thinking that it is because of its long intracranial this one route. This is the reason that it is involved more. Is it my statement correct? Have you heard about it?
No, sir, not heard. Not heard about.
Okay, anyways, just a second. Abducent. Yes, I was correct. Okay. Of all the cranial nerves, the abductor nerve had the longest intracranial route course. Okay. The knowledge is a ibadat. Knowledge is a worship, believe me. But worshipping this book is haram. Believe me. I'm really sorry, because I'm so disappointed. I'm so feeling it's, being your colleague, I feel insulted. I don't know why you people are not feeling insulted to read this book, because I am getting the response that, sir, paper is coming from this book, so we should read it. Okay. So unfortunately, I'm really sorry to say this is absolutely wrong. Anyways, the other question, I think this is copy paste from some book, and this is wrong, because I was just thinking about this one, because it will be accompanied by tinnitus and photophobia, aggravates on sitting, occurs in frontooccipital. Yes, usually self-limiting in nature, but usually it is unilateral. Which headache is usually unilateral? Can anyone tell? Which headache is usually unilateral?
Migraine.
Migraine. Okay. So, you should have a differential diagnosis of headache whenever you are discussing about PDPH. Okay. So incidence with 27 gauge, I don't remember the exact incidence, but you can find the exact incidence for this PDPH. Okay. So Zishan, if you can just start helping me, whatever, whenever, as much time as you have, we can start this jihad. Okay. Anyways,
Inshallah.
the question on das, because this question comes in a number of times. Usually the concept of das will be that whatever they are doing it, there will be one thing will be anticipated and one thing will be unanticipated. This is one thing. So anticipated, usually one scenario will be for thyroid or big thyroid, that will be a separate thing. But usually anticipated one, which we are facing frequently, is the pregnant patient. Okay. So pregnant patient is usually if considered full stomach, and there is also incidence of difficult airway, higher incidence. So now the thing which will be deciding the management will be the fetal distress. So even if you open the DAS algorithm, you will find the same thing which I'm telling you, that if there is fetal distress, you have to proceed even with LMA. If there is no fetal distress, you will awaken the patient and you can go for alternative spinal anesthesia or something like that. Okay. So this will be, this is 3+1 for patient without risk. If just correct me, Zishan, because you have recently read it. 3+1, 3
Yes,
attempt,
sir.
and then one by by an expert one in case of without at risk. Am I right? Without risk of aspiration, and in emergency
Yes, sir.
or anticipated, you have to do 2+1. Am I right?
Yes, sir.
And
Even
then
in RSI, you have to
yes,
do 2+1.
and the next step will be the plan that you will be maintaining the oxygenation, and then you will be trying to put an LMA. If you are not able to ventilate, you will try to put an LMA. If you are successful, you will awaken the patient if there is no emergency for the surgery. But if it is emergency, you have to proceed with it. You can put an intubating LMA and you can try to intubate, but you will not stop the surgery, because if you have, this is especially true in case of pregnant patient. Okay. So whatever question will be coming will be on these bases. So what 2 attempts taking, take the third attempt with different blade and repositioning the patient, or by expert. Multiple attempts taken and not able to ventilate, insert LMA, correct. Multiple attempts, elective procedure, easy bag mask, awaken the patient, correct. Multiple attempts, emergency procedure, can bag mask, proceed with bag mask, correct. Not bag mask, you will try to put an LMA. What about Zishan? What do you think? I have doubt about
Sir,
this.
if the LME is failing, it has failed, but the bag mask is, you can proceed with bag mask.
Yes, but this is a half statement. Okay, you will definitely try for LMA, because with the LMA or iGel with less airway pressures, you can proceed. There will be less risk of aspiration, but you are doing the continuously with bag mask, there will be high risk of aspiration because there will be aerophagia. Okay, so I think these three statements are correct. Maybe here, but this statement is a little doubtful. So multiple attempts failed into intubation, LMA inserted, still cannot ventilate, Kiko, emergency crico. Yes, multiple attempts failed intubation, cricotherapy done, elective, wake the patient up, cricotherapy. Okay, wake the patient. Yes. Okay, fine, this is correct. Multiple attempts failed intubation, cricotherapy done, and can ventilate through it. Emergency procedure, proceed if cricotherapy done. Of course, in emergency, you will do it, and also you will call for proper tracheostomy. Okay. Multiple failed attempts, needle cricotomy done, can only ventilate for now, emergency, fetal bradycardia, wait for ENT surgeon and proceed only after a definitive airway is formed, because needle isn't a definitive airway, proper current is. Fetal bradycardia, you will not stop, you will proceed. Fetal bradycardia, if you are able to ventilate the patient, you will proceed. This is also wrong statement. Any comments about it? They are saying that you have done needle cricothyrotomy, but there is emergency and fetal bradycardia. So you will not wait for ENT surgeon. You will not wait for ENT. Baby will fly to the heavens if there is fetal bradycardia and emergency. And so you see, this is disastrous. These sort of statements make me hate this terrible source. Okay, so I hope you understand some of the points. Any questions or any comments from any person? Because Dr. Mehnaz, I would like to listen from you, because you are the voice of the people who are appearing. Imran, Mehnaz, I don't know about Rabia. Yes, please, because they are from outside. Dr. Humaira is still young. Yes, Dr. Mehnaz.
Sir, I just reading this book
You
because of you. Because you
because
are
of me?
teacher now.
No, because of
you are
me.
teacher.
I hate if for example, if I were in Pakistan, I would have gone to meet these people, believe me. And now I'm planning that whenever I go on vacation, I will try to find out this Dr. Ayesha Baig, Asim Shoaib, SK. I want to go
Umar
home.
hai yaar.
Please, like I would like to beg them, please don't destroy the future of our residents. Literally, I will beg them that
Yes, sir.
please, on behalf of whole of the anesthesia community back in, or whole of the nation, I am begging you, please don't destroy the future of our residents. Okay, that's what maximum I can say.
Yes, sir, you are right.
Okay, so next question is advantages of glycopyrrolate as an anticholinergic versus atropine. So when you are thinking about it, yes, this is the reason that it does not cross the blood-brain barrier. But extra thing, you should be knowing the chemical nature. What is the chemical nature of glycopyrrolate and what is the chemical nature of atropine? This is one thing. Duration of action, onset of action, and incidence of central anticholinergic syndrome. They have not written here. There is more incidence of delirium. Okay, it can cause atropine, will cause sudden and very brisk response. So it can lead to even any unwanted cardiovascular incidents, because if suddenly there will be tachycardia, the patient can go towards ischemia. There may be precipitation of any arrhythmia. There may be precipitation of myocardial infarction, failure. So that's why atropine is not at all a good choice unless it is needed. Okay, unless it is needed, atropine is never a good choice. And another reason for not using atropine in reversal is that atropine and neostigmine does not match. Neostigmine effect comes a little late and remains for longer. Atropine effects come very quickly and goes wean off, finish quickly. So there may be side effects of neostigmine which you are trying to avoid. This can occur. So this is the main reason for not using atropine. Okay, so atropine should always be used. People have written anti-salagogue effect. This one more anti-salagogue effect. So, and this is not the reason for using it. Okay, anti-salagogue is with atropine is also good, but although it has more anti-salagogue effect than atropine. Okay, there is another medication which is there, which is hyoscine. Hyoscine is also scopolamine or hyoscine. It also has good as anti-salagogue effect. Okay, so I like this, it's like that. Then this question of post bronchoscopy secretions. Post bronchoscopy secretions are treated by glycopyrrolate flumazenil. There will be a scenario, but bronchoscopic, if you can just revise some of the points related to bronchoscopy, Flumazenil, you should be knowing what is the dose, what is the mechanism of action, what are the side effects. If you are using flumazenil, how to use it, what will be the dose, what will be the side effects, and what are the other CNS stimulant which can be used for reversal. The other one is naloxone, okay, and another one which may be asked, it's not available in majority part of the Pakistan, or I don't think so it's available in Pakistan, or I'm not sure about India, but I don't think so it's available in Pakistan. Its name is doxapram. Okay, so doxapram is a CNS stimulant, and it stimulate the respiration. It's a CNS stimulation. It causes generalized CNS stimulation. So this is also, so whenever you are exercising your brain, you have to do like that. Okay, so bronchoscopy, the other problems which can occur post bronchoscopy, one of them is patient will cough and cough and cough. So secretion is one of them. Even if you dry down the secretions, the cough can increase. I repeat my statement. If you dry down the secretions totally, the cough will even increase. So you need something else as well. You need to give some lidocaine. So lidocaine is a thing which if you give, I have tried even myself, you have to soothe down because there is, like, you are playing with the airway. So the things which you can use after bronchoscopy is nebulization with normal saline, and not for bronchospasm. Okay, and lidocaine is one of the treatment which you can use, because lidocaine will just give a membrane stabilizing effect. Okay, and depending on the scenario for the thing for which it has been done, you can like use some of the medication. Still, if there are too much secretions, and the patient is not able to cough it out properly, like there is weak cough, there is cough, but there is weak cough, then you can use even mucolator sachet. Okay, this N-acetylcysteine via nebulization or through oral route, which can make the patient able to remove the secretions easily. This is the same basic mechanism which you are using in the ICU as well. Okay, so like bronchoscopy will be for either diagnostic purpose or therapeutic purpose. They are doing it even for bronchoalveolar lavage. They are doing it for confirmation diagnosis of this tuberculosis or any things like that. So there are so many reasons for bronchoscopy. They can use it, but the points when you are reading one MCQ, you should be thinking about it. I will just take one more minute to. Someone was saying that this is recall MCQs. Yes, this is recall MCQs. Remember one thing. Another one of the doctor, she was complaining that CPSP don't have the practice pool. So remember one thing. Even the Royal College of Anesthetists or College of Anesthetists Ireland or any college in the world never publish their pool, because they have limited resources for that pool. So they never actually, they never want that someone comes out and reproduce them. And rather, I tell you, there may be some legal action against any person who claim to create a pool like that and publish it. If for example, if there may be some legal action for corrective measure, not to destroy the career of anyone. For corrective, there should be strong message from college that if anyone publish such sources, there will be strict action taken against them, because this is wrong. You know, if that person is making it a correct pool, fine, there is no problem. But if he's just trying to supply a haram, an illegal and a distracting thing, which is destroying their concept, but I cannot use more slang language than that. It's a crap. They are just destroying the mind and the concepts. So the books which are published, which we follow, FRCA, you open the book and every book they have written practice. And I can guarantee you that none of the paper comes from those books, because of course they spend a lot. Whosoever is making the questions, they pay a lot. Okay, and they are getting the results. So the MCQs which are printed in any MCQs books, usually they are not the questions from their pool. Even the people who are preparing from PLAB, they can correct me, because I never went for such pools. I just read them as a practice, and I never not even a single MCQ which I found from any book. I appeared in European Diploma in Anesthesia. I appeared in European Diploma in Regional Anesthesia. I appeared in Irish Fellowship. Once I appeared in European Diploma in Intensive Care. I did not find even a single question from the practice books which I did. So I can say it by a surety that there is no correlation between the books which are published in the market for practice and the original exam. Unfortunately, in countries like our country, we don't have that much resources. Our people are so much struggling in the financial circuit. And of course, let's just tell me, the people who are passing the exam through this source, they will become consultant. And what are you expecting from them? Just tell me. So I feel insulted. This is my insult. I feel ashamed when I see people following this book. I'm really sorry. I'm getting too much emotional, and maybe some people are not interested in listening this thing. They say, sir, let us pass the exam. The knowledge we will get throughout the life, and they will never do it. I can guarantee you. I can guarantee you, because they will become the same sort of consultant which I faced. And that's why I decided at that day that inshallah, if God gives me the chance, Allah gives me the chance to have some knowledge, I will not reply. You know what sort of answer I used to listen? Please, you read and then we will discuss. They never answer the question, and they only say read and then we will answer. So that thing will never happen. In our slang language, na normal tail hoga, na radha nachegi. Then you will, for example, if some lady wants to dance, she is asking for 9 tons of oil. Okay. So there will be no one will be able to bring 9 tons of oil. And so she said that till the time you don't bring 9 tons of oil, I will not dance. So that is the example of what I am telling you, that this will never happen. So this is a vicious cycle. So I am trying hard, and I have committed myself. I will keep on doing till my last breath. You people are happy to join me. I'm not doing it for any. That's why I will never open my camera. So I don't want to show that I'm something out of the world. I'm just trying to help you out. Even I try to invite people from India, from African countries, from some Egyptian countries, whosoever. I send the link to so many people. I know I'm not getting any reward. Even 13 people have joined. Okay. Out of them, one of me, only 12 people. Why? Because people think that this is not practical. We have to pass the exam. So that's why the system never changed. Okay. So there is a question. I have a question. Can dexamethasone be given to a patient for cough? Just tell me one thing. Dexamethasone, what will be the mechanism of action? It will be acting as an anti-inflammatory. Okay. So inflammation, as I told you, that you can give, if you want to get the effect quickly, the choice will be hydrocortisone, not dexamethasone, because dexamethasone will take some time for its effect. So if you want to get the effect, if you are thinking that there is inflammation, you can give both of them actually. You will give hydrocortisone so that the effect will come quickly. And then you can, later on, you can give dexamethasone so that it continue for its effect. Another thing is that if you are expecting any edema with the same reference of this bronchoscopy, you can advise this one, racemic epinephrine. Okay. Racemic epinephrine, which is being used for nebulization. Okay. So you can use that as well. Any other point which I have missed for this bronchoscopy? I think these are the things which they will be asking. Of course, the bite block and how the use of antisalagogue, and then the rest of the thing I told. Oh, I hope I answered your question, Abid. Dr. Abid, did you get your answer? Okay, so anyways, neostigmine, slower onset, atropine, fast onset. Adrophonium, actually, adrophonium is never practically used. Adrophonium is only being used for the stencil-on test for the diagnosis of myasthenia gravis. Okay, so I don't think so. Practically, they never use it. Okay, so like they ask in the exam. So adrophonium and atropine is a good combination theoretically, because both of them have the similar kabila, the same tribe, coming effect quickly, weaning off quickly. So adrophonium and glycopyrrolate, or this neostigmine and atropine, these are not correct concept. Okay. Okay, a 68 years old woman is to undergo foot surgery under spinal anesthesia. Which of the following statement concerning the immediate physiological response to the surgical incision? The cardiovascular response to stress will be blocked, but the adrenergic response will not. No, both of them will be blocked. The adrenergic response to stress will be blocked, but the cardiovascular is not. Both will be blocked. Okay, neither the adrenergic or cardiovascular. Can someone tell me what is the stress response? What is this surgical stress response? How it occurs? Can anyone tell? Yes, Wajia, are you Wajia from Jinnah Hospital? Wajia Anis? Can anyone tell what is this stress response and what is the role of spinal in it? Speak out, please.
So is this due to cortisol stress response?
Yes. Actually, the whole of this, whenever there is a stress, there is a stimulation of sympathetic system. Okay. So when they are giving the incision, from that place, this pain response is occurring, and it is not only causing the local response, it is going as a pain pathway. They have connection with the autonomic system. Okay. So the basic response is that. That's why we don't have the habit, but if we make a habit to ask the surgeon to give some local anesthesia before incision, this will be a very good effect actually. That's why if you are giving a regional anesthesia or spinal or even epidural along with general anesthesia, this will make your life very easy. Okay. I now practically see that if they are doing a humerus surgery and I have given supraclavicular block, now I just, if anyone is standing with me, when I tell that if you want to make sure that my block is effective or not, have a look on the monitor. And if it is not going beyond 5 to 10 per beat, like average of less than 10% or around less than 20%, it means the block is effective. And majority of the times, if I have given a good block, that yesterday, even day before yesterday, I was seeing the heart rate did not go beyond from 60, 65 to 70. It was just throughout the at least 3 hours. Okay. So this is the concept that whenever, that's why nip the evil in the bud. Nip the evil in the bud. That is the concept of multimodal analgesia. So that is the same answer here. If you are blunting the stress response, even the hormonal response will be blunted a little bit. Okay. That's why we say that all the effect of cortisol and this insulin problems and everything will be increased if you have not given a good analgesia. Okay. So, and that's why, for example, if you are not giving that one, then that's the concept of another thing, Zishan, MAC bar. You know about it. What is anyone knows about it? MAC bar. Do you know about, anyone wants to answer this question?
So I think MAC bar is the minimum MAC which will prevent the patient from moving.
No, my dear.
Or the patient will wake up beyond that.
No. What is bar?
Go,
What is bar? Actually, I have not opened my pen stylus today. Just a second. It is my civet. Actually, BAR is for blunt adrenergic response. Okay. So the MAC bar is the MAC which will result in blunting of the adrenergic response. Okay. So that is around 2.5 to 3 MAC. Because we don't have that machines in our country. I hope people from India are you getting it? The MAC bar is, if you have a monitor, which is telling you the MAC value, not the percentage. Forget about percentage. I'm talking about in modern anesthesia machines with the agent analyzer, they are telling you MAC. Okay. So if you want to blunt the adrenergic response, you have to bring the MAC value, not 1, you have to bring it around 2.5. In that case, you will be able to blunt the adrenergic response. Okay. This will not be possible in every patient, because if you are giving that much only inhalational agents, what will happen that there will be other hypotensive effect will prevent you from doing so. So that is why the concept of multimodal analgesia is a wonderful thing, because that's what I'm using practically. And that's not written, that's there is some, I don't know the name of that Indian doctor who is doing, who is who is selling this point of cocktail anesthesia. And actually I was doing it before at that well, and then I came to know that there is officially some doctor, I don't know his name, maybe some of you can help, that he's using small doses of different medication. Like I just tell you that just this concept, Zishan, that around I'm using not more than 50 milligram of propofol in any patient for induction, believe me. But why I'm getting that effect? I am giving around 25 milligram of ketamine. I am giving around 50 mics of fentanyl. I am giving around 2 milligram of midazolam. I am giving paracetamol and NSAID, any NSAID, whatever is available, paracetamol and NSAID before intubation. Okay. And I am starting a very small dose of dexmedetomidine while I am intubating. So like, and also, yes, one more thing is that I'm also loading the patient with morphine a little bit. Okay. So like people are giving morphine in the mid of the surgery or towards the end of the surgery so that they are covering for post-op pain, but they are unfortunately denying the intraoperative effect of morphine, which they can get in a wonderful way. Okay. So my suggestion that if you are giving a multiple, because fentanyl effect will finish in 15 to 20 minutes. Okay. Fentanyl effect will finish in 15 to 20 minutes. So if you are giving morphine on top of it, by the time you are giving, when you are putting the monitors and everything, starting pre-oxygenation, or that time you are already given morphine. Okay. So what will happen by the time they are giving the NCN, the morphine effect will already come. Okay. So this will give you a wonderful response. And this is called as a cocktail anesthesia. You can say that a number of taste, and because all of these medications are reducing the requirement of other medication. So if you are using good dose of muscle relaxant, if you are giving propofol, ketamine, midazolam, fentanyl, morphine, paracetamol, and Zifo before you poke the laryngoscope in the mouth of the patient, the response will be wonderful. Okay. And the concept is the same which they have written here, that it is like adrenergic and cardiovascular response, which I'm telling you. Okay. So I hope it is clear. Any points about any other comment about this question or this thing? Okay. So the next question is, with aspiration pneumonia presenting as a lobar infiltrate, which side are the most common? Why this right lower lobe? What is the reason for it? Because of course it will be trickling down. The right bronchus is more in line with the trachea, so it will tend to trickle down towards that area. Okay. Okay, what is the next question? A patient with coronary artery disease and bronchospasm presents with SVT. What would be the reasonable medication to give? SVT. So now the answer, whatever answer is written here, you should be thinking about the ACLS algorithm or European Society of Cardiology algorithm. Okay. So you should be thinking in that way, that you will be doing some like this one, vagal maneuvers, cold, ice cold, this carotid sinus massage, and then you are looking at the hemodynamic instability If it is there, there is a hemodynamic instability, you will immediately go towards synchronized cardioversion. If it is not there, then you will go towards the medication. So here, because bronchospasm, so adenosine is actually can exaggerate or to be avoided in patients with bronchospasm. Okay, this is one thing. So adenosine option you will try to rule out. They have written here procainamide lidocaine has no role. Beta blocker adenosine cannot be given in bronchospasm. So beta blocker and adenosine will be out because of bronchospasm. So digoxin and verapamil. I still doubt what will be the role of digoxin. Is there any role of digoxin according to ACLS algorithm in SVT? Can anyone tell? Any comments? Because among this option, procainamide and lidocaine usually in the broad complex, not the narrow complex, because SVT is narrow complex. Okay. So beta blocker adenosine, they are saying it for the bronchospasm. So the remaining choice in this option, if they have written, so I think the first choice or first thing will be verapamil. I'm not sure about the role of digoxin in SVT. So I have a doubt about it. You can reconfirm about it. Okay. The next question is, which of the following, we will just, I think, 2 or 3 more questions and then we will finish because it's almost 1 hour now. Which of the following drugs would be expected to increase sympathetic discharge or mimic the effects of increased sympathetic discharge? Would not be expected to increase sympathetic or mimic the effects of, mimic is something else. This question seems to be a little doubtful. What they want to say. Would not be expected to increase sympathetic discharge means it's not increasing the sympathetic discharge. Or mimic the effect. Okay. Like, so neostigmine can cause, it has no relation with sympathetic system. Amphetamine, it will increase the sympathetic discharge. Isoprenaline, it will increase mimic like effect. Okay, because it is beta agonist. Methoxamine, it is alpha agonist. So this will also increase vasoconstriction. So it will also mimic like increase sympathetic discharge. So the only medication here is prazosin, which is alpha blocker. Okay. So now you can also revise that what is the effect of alpha blockers. Like whenever they are being used, they will cause reflex tachycardia. Okay. So this is one of the problems with alpha blockers. So then again, you can revise what is the role of amphetamine. You know, that's how you should be. This is practice. So practice should be done in a way of practice. If any one of you don't know about methoxamine, just Google it. What is methoxamine? And you will find few points and you can note down in your book. Okay. Similarly, prazosin. I told you the things to remember about prazosin. Prazosin is alpha blocker. So you can see on which alpha receptors it is predominant. What are the different uses of any medication? So similarly, like isoprenaline, it's pure, I think, beta agonist. So beta 1, beta 2 also. I'm reconfirm. I'm sure I think it is pure beta 1. Can anyone correct me, please? Isoprenaline, is it beta 2 effects also or no? Because all of you are silent, so I think I'm talking to myself. Anyways, just reconfirm it. I don't remember exactly. I think it is pure beta 1, but if maybe it also has some effect on beta 2. Okay. Administration of a drug that blocks beta adrenergic receptor would not be expected to. Okay, so they are talking about a medication which blocks beta receptors. So it is beta blocker. Would not be expected to. So it will not do. So beta blocker will do what? Beta blocker will reduce the heart rate, reduce the contractility. If it is non-selective, so it will cause bronchospasm. Okay. So it will blunt the response of stress like this hypoglycemia effect will be reduced. So now see, so it will decrease the heart rate, it will decrease the contraction. Okay, it will decrease the secretion of renin from the kidneys by blunting the stress related stimulation. Okay, it decreases the secretion of insulin from the beta cells of pancreatic islets and will not cause bronchodilation. So it is the correct answer is mentioned here. But you recall the topic like that. Don't try to see only cram the answers. Just revise. You should at that time, you should immediately, because when you are appearing in the exam, the things should be revised again and again and again. So at that time, you should open your diary or book from which part you have read. Just recall where are the different beta receptors and what are the effects of different agonist or antagonist on different beta receptors. So then at that time you can also revise, and then you will not be able to miss the answer, I can guarantee you. Okay, so that is how you can use only one MCQ to learn. Then Chasnick tubercle is eponym for, I think this is for this stellate ganglion block as well. Apex of thyroid cartilage. Now you can revise. Maybe I'm not able to tell you the exact levels, but you should be revising where are the different levels they have put it. What is the significance of this all points? Greater horn of hyoid bone. Which level of vertebra it will be? Just have a look. Okay. Tip of mastoid. Tip of mastoid, is there any block or any landmark which you are doing it from that thing? You can revise. That's how you will revise the anatomy as well. Okay. So anterior superior iliac spine, you are identifying it for this inguinal area anatomy. You are, before they used to perform the blocks with this reference point. Okay. So once you are reading this, because this will not be written in your the explanation, even this is a recall. They have copy pasted some of the questions from the books. I can sense, if you are reading it at your home, I will suggest you are reading any MCQ book. Try to read like that. Maybe I'm not able to recall it at the moment, but open the book and recall, or even whatever source you are reading. This is way how you can expand your knowledge, and then even this Ayesha Baig will become a holy book. Okay. Okay, local anesthetic produces conduction block of nerve impulses by. So don't read it here. Then just first of all see what is local anesthetic. So local anesthetics are sodium channel blockers, which are blocking the sodium channel from inside. Okay. So now you will be knowing that how will they work. So now hyperpolarization, the resting and transmembrane potential. No, they don't do this. Preventing increase in permeability of nerve plasma level to sodium ions. I think this one. Increasing the nerve membrane threshold potential. No, I'm not sure about, because this is a different statement. Let's see the other. The hyperpolarization is definitely no. Increasing the nerve membrane threshold potential. No. Preventing increase in permeability of nerve plasma level to potassium ion. No. These are three are definitely wrong. Incompetitive blockade at the presynaptic receptors. This is also wrong because they are acting in the sodium channels from inside. So though I am not sure about this answer as well, but this may be the correct one because all others are definitely wrong. Okay. So sometimes you will be finding the answer not by correcting, but by seeing other options are definitely wrong. So in this case, I have not read or I don't have the concept about this specifically preventing increase in permeability of nerve plasma level to sodium ion. I think that when their sodium channels will be blocked, so permeability will be decreased. So that's what they are trying to say. So now this will be the last question for today. Which of the following patient would be least likely to develop a decrease in heart rate with high C8 placement of spinal anesthesia? Who will place the spinal at C8? 15-year-old with T6 paraplegia, 45 years old patient with glaucoma treated with pilocarpine, A 33-year-old with T6 paraplegia. I don't know what is the a 45-year-old diabetic man with a history of orthostatic hypotension, least likely to develop a decrease in heart rate. Like heart rate will not decrease. So paraplegic patient will have decrease in heart rate. A 45-year-old with glaucoma treated with pilocarpine. I don't know what is this question. Is this from Bryony Hall? Anyone is aware of this MCQ?
No, sir. I don't think so. It is from Brennan.
Anyways, I don't know in what aspect they are saying that diabetic man with a history of orthostatic hypotension. I'm sorry, this question doesn't make any clear sense to me. If anyone can help me. A 15-year-old with T6 paraplegia, what will happen in this patient? Or now try to have one by one. A 15-year-old with T6 paraplegia. So T6 paraplegia means the cardioaxillary fibers are spared. So the response will be intact. Okay. So now they are saying like least likely to develop a decrease in heart rate. I don't know. Anyways, this will a 45-year-old pilocarpine. What is pilocarpine? It's parasympathomimetic. So it decreases the heart rate. Okay. So maybe they are saying that it is already decreased, so it will not decrease further. I don't know about this. A 33-year-old with T6 paraplegia. 33-year-old. I'm sorry, this question doesn't make any sense to me. So I think that's change in sensitivity of baroreceptors, best I could find. I will try to have a look on this question later on. Okay, all of you, thanks a lot for your presence. And again, my last message is that if you want to prepare yourself in the exam, even if it is MCQs based, you should prepare in a way that you know the concept. If you don't have the concept, even if you pass the MCQ exam, I guarantee you, you will be stuck in Viva. I can guarantee you this thing. So this is one thing, and some sort of moral thing, that if you are trying to bypass the system and you are just trying to have shortcut and you don't know the subject, remember one thing, you will be embarrassed throughout your life. Because if you don't have the knowledge, once you pass the exam, you will never study, I can guarantee you. You will always try to have escapes. And for example, back in Pakistan or India, after finishing your board, if you are appearing in some international exam, they are very smart. You will not be able to pass any international exam if you don't have the concept. Okay. So this is my message. Don't try to bypass the system. Don't try to have these terrible crap pools and just trying to only cram the answers. Don't invest time. Don't be in hurry up. The people who are appearing in intermediate module, you know why you are in so hurry? Why are you in so hurry? Take your time. Intermediate module is a dress rehearsal of the final exam. You should be appearing in the exam when you are fully prepared for final exam. I suggest you that you should think after 2 years or 3 years, maybe you give, but you should appear in the time when you think that you are capable to appear in the final exam. Then you appear in the intermediate module, and I can guarantee you will never fail. But if you are looking for shortcuts, right now what's going on in Pakistan, that there is a communication between College of Physicians, Surgeons and Irish College of Anesthetists Ireland, and they are sending the people to Ireland for 2 years training. I have strong objection on that one as well, because the people who just make their goals very low, okay, it is a big thing for them. But the people who have high goals, and remember one thing, you can go to Ireland or UK after passing your exam very easily at your own. You don't need such gifts from the college. Why? Because actually this is in more support of the Irish system, not for you. Why? Because they are not giving you anything other than salad. They are not giving you any proper meal even. Why? because they are not giving you any entry or any exemption or any favor to enter in their system. They will use you for 2 years because they know that you are coming from Pakistan. You are very well trained in 2 years. You have passed the exam, not well trained. They know that you have the knowledge, and they can use you to strengthen their system. I'm very sure about it. But unfortunately, because our college, they sell this thing out of the world. Oh, we are sending you to see the lights. We are sending you to see the beautiful valleys of Europe. So please rush for IMM. Don't take any measure of your future as a whole, just because it's something very out of the world. Come, pass the IMM in first attempt and go to Ireland. And I tell you something, time is money. The people who go to Ireland from Pakistan and through this route, they at least waste at least 1 year or near to 1 year. Because what will happen, the 3rd year of their residency will be wasted in the process of Irish Medical Council registration and all the requirements and etc. etc. And they will have to spend 2 years there. So actually they are wasting their time. So yes, if you are thinking that it is out of the world to go to Ireland from the ticket of CPSP, okay, you are selling yourself at a very cheap price. You can go to Ireland after passing your FCPS, and that will be your free for it. Okay, you can do it, and whatever Irish experience you want to take it at your own. In that way, when you are going through CPSP, you have to come back, you have to report, or the other thing which people do, they bypass. They say, thank you very much, CPSP. We are not appearing in your exam. They pass their college exam, they pass the MCAI, and they pass the FCI, and they are slipped out of it. And there are so many people who wasted their career by that route. So even in that aspect, it is wrong. But unfortunately, if I say this thing, people start stabbing me. Oh, who are you to point out our system? Who are you to stop people going for a better setup? Yes, there are, I can tell you 1000 advantages as well. You are in the Irish training system, fine, no problem. But why you are thinking that after finishing FCPS, you cannot do these things? You can do it. So there is no fun, because I tell you, people don't know the reality. Irish Medical Council registration is something else. College of Anesthetists is something else. They are never allowing you to enter their training system. If they allow to enter their training system, even I am happy to go at age of 42. If they are offering me, okay, Dr. Zishan, you have enough experience, we will train you. They will never ever let you enter in the training system. They are asking you, the only thing is that if you are working there, you have to finish your modules of their requirement at your own, struggling for jobs, looking for the jobs at the places where there are rotations for that specific. So certain rotations are very hard to get, like pediatrics, thoracic. There are few hospitals of pediatric or thoracic rotation in Ireland. So you will have to struggle a lot. Okay. So if you want to torture yourself, go ahead. Otherwise, Ireland is a very small country as compared to UK, and it is not wise to waste your life thinking that you will be getting out of the world. Yes, I again repeat, there are so many good things. I know a number of people who say, who both husband, wives are residents, and they are going there. They are saying, no problem, we will stay there. We will not go back to Pakistan. They are trying to just have on that. They will stay there. In 6 to 7 years, they will be able to finish their rotations. They will present to their college and they will become consultant. But in my opinion, you are degrading yourself. So I am totally against it. So that's my point of view. The CPSP people are in front of the home. I spoke this. They are always very angry that you are coming from Saudi Arabia and distracting our people. This is the statement which I listened from one of the person who now is the college president. He pointed at me, and because I was just arguing with him about something, and he said to me, Dr. Zishan, you are coming from Saudi Arabia and you are distracting our people and you will go back. This was really insulting. I don't care, but it was insult to all the people sitting over there. Why? Because I was just trying to say something for them, not for my, I have out of that thing. I have finished my fellowship. I'm enjoying my life, alhamdulillah. Okay. But I don't want my fellows to be insulted, because you people are insulted in Ireland. If they are not offering you training, why you are going there? Just tell me. Why should you go to a place where you are getting a training program? Because the exam, I'm sorry, I'm taking few minutes. I will tell you one more thing. The people think that the exam is something. Our Pakistani or Indian system is different. We have exit qualifications. We have exit qualifications. Once we finish FCPS, or once we finish DA, or once we finish DNB, we are consultants. Okay. The MD degree of India, or DNB of India, or MCPS of Pakistan, or even DA of Pakistan, or even FCPS, all these are exit qualification. Our system is that we are only eligible to appear in the final exam once we have finished all the prerequisites. Irish system is, or UK system is totally different. Exam is separate, training is separate. They have opened the pathway for exams. I'm really sorry to say, but it is for financial purpose, because they know the people coming from Asian or people coming from a poor country, they will be very happy to get a degree with the Royal College, for College of Anesthetics. Oh my God, I have achieved heaven in this world. But actually, reality is that it is only a paper. It is only exam. It is not a degree. It is useless without the training. So if they are not offering you training, and you are only getting the training if you are very good, they are testing you. You have got the letter of recommendations. You have got the requirements of their system. Only then you are able to get registered in the specialty registrar. Okay. So for that, the terminology, I have discussed this thing in detail in career counseling. It just came into my mind. So I'm again speaking out. Please spread the message to everyone. Don't sell yourself at cheap price. Going to Ireland via CPSP is not attractive at all, because your loss is more. You are getting something in shortcut or in quick way, but in long run, you are at loss, because you are moving one time with your family and you have to come back. And again, you are at 0.0. Okay. You are only getting some exposure, which is, I don't think so. It's something out of the world. Once, you know, I'm from the same Pakistani system. I didn't know how to hold ultrasound. And I still remember 2012, I finished my training. I was in Saudi Arabia. I don't know even how to hold the ultrasound probe. And now I am doing all the blocks. So how? I was not here in teaching position, training position. I learned. If you have the common sense, you can learn anything if you want. Yes, you have to struggle for that. I spent so much money on studies and getting myself competitive to any other part of the world. But you can do it. I can guarantee you can do it as well. But you should be on the right track. Okay. So thank you very much. And again, remember, don't respect yourself. Give respect to yourself. If you will not give respect to yourself, nobody else is interested to giving you respect, because the world is still, we are human beings, but actually we have the same animal instinct, survival of the fittest. If you have the links, you will survive, you will flourish. Thank you very much. Bye-bye. Any question or any comments? We will continue this Ayesha Baig sessions, inshallah. This question was beyond my understanding. I will try to find out the answer for it. We will continue from question number 26 later on, inshallah. Okay. Bye-bye. Imran, I will tell you something. My thanks, if you want to thanks me, I don't want this word. If you want to say thanks to me, respect yourself. Change your way of studies. That is my thanks. I don't want anything else. I don't want anything else. I'm not interested to have pictures with you people and post on Facebook. Okay, that like our supervisors do. And I have strong opposition for that. This is actually their insult. They think they are showing their greatness. Unfortunately, this is not the greatness. This is their insult. Unfortunately, they don't understand. They don't appreciate. Okay, so if you, all of you, whosoever is listening to me, wants to thanks to me, please change your track. Please respect your knowledge. Please respect yourself. Don't look for shortcuts. Be a good anesthetist. Be a good anesthetist for your family. Think that you have to anesthetize your mother, and you will never ever try to have experiments on her. Am I right? So don't experiment on anyone else's mother as well. Have the knowledge. Anesthesia is literally not because I'm an anesthetist and you are an anesthetist. I'm telling you something. Anesthesia is the most delicate field of medical science. And if you don't have the knowledge, intubation, blocks, spinal or intubation is a technician's job. Even technician can pass endotracheal tube. A technician can give spinal. Okay. Even nurses can do CPR. So if you are thinking that if you are able to have a very good chest compression, this is paramedical staff job. If you think that intubation is anesthesia, intubation, I think a senior anesthesia technician can do much better intubation than you. Similarly, spinal. Okay. So come out of this, have the knowledge, clear your concepts, and then you will feel satisfaction, which I feel really. I feel really satisfied by myself, and I love anesthesia more than I used to do yesterday, because this is a specialty which is so demanding. You should be knowing each and everything about the medical science. Believe me. Okay. Thank you very much.